Hello everyone, welcome to this video on the anatomy of the abdominal cavity. I have exams soon, so I thought this would be a fun way to revise and teach whoever's interested in this on YouTube as well. I'm using my notes based on my university's anatomy guide and also some pictures taken online if you're interested. Do feel free to ask if you have any questions or if you want any links to resources or anything you've seen in this video. And please leave a like and subscribe if you like this video. So, the abdominal cavity, when we're talking about the abdominal cavity, we are talking about a space in the middle portion of our bodies which is lined by this peritoneum, which covers the anterior and posterior abdominal walls, as well as the organs. So we have the visceral peritoneum lining the organs, you've got the liver, stomach and intestines, and then you've got the parietal peritoneum lining the outside. So that forms a space called the peritoneal cavity, and we can see that here as well. So we've got the liver, the stomach, and then between the liver and the stomach, we have what's called the lesser omentum, where the peritoneum folds over the organs, and we have the greater omentum posterior to the stomach, and that connects with the lesser omentum through the epiploic foramen here. We can see that better on this diagram. So anterior, posterior, right, left, we're looking from the feet upwards. And we can see that the epiploic foramen is here between the liver and the stomach. And then we have the free edge of the lesser omentum, which contains some structures that I'll get into later, and the lesser sac. So these are the kidneys. This is the L1 vertebral body, spleen, stomach, liver, and some muscles. And then we have these vessels, so the aorta with the inferior vena cava on the right, and then the superior mesenteric artery with the superior mesenteric vein on the right. So as I said, the walls of the abdominal cavity are lined by the parietal peritoneum, lines the anterior and posterior abdominal walls and the inferior surface of the diaphragm as well, and the pelvic cavity. The visceral peritoneum is a continuation of the parietal peritoneum, so this is all continuous, and it's reflected at places over the abdominal viscera, like the falciform and the coronary ligaments of the liver, and the greater and lesser omentum, as well as the gastrosplenic and lienorenal ligaments. And they form the bases of the mesenteries of the small intestine, the transverse and the sigmoid colon as well, which we will get into later. The peritoneal cavity, what is that? It's a single continuous space lying between the parietal and the visceral peritoneum, and as I said, the greater sac communicates with the lesser sac via the epiploic foramen. The greater sac is posterior to the stomach, so you can see here the stomach, and then the greater sac, part of the greater sac here, as well as the lesser sac. That's posterior to the stomach, and then anterior to the pancreas. The peritoneal cavity is divided into supracolic and infracolic compartments by the transverse colon and its mesentery. So the transverse colon is here, and this is its mesentery, which is formed by the visceral peritoneum that surrounds it, and then that's the supracolic, so above, and then the infracolic compartment below of the peritoneal cavity. So how is the GI tract divided up? Well, it's divided into three regions: the foregut, which is the stomach and part of the duodenum, and the midgut, so the duodenum to part of the large intestine. So basically most of the small intestine, and then the hindgut after that, for this part of the colon. And this is according to the embryological origins, and each of these three parts have different blood supplies. So the foregut is supplied by the celiac trunk, the midgut is supplied by the superior mesenteric artery, and the hindgut is supplied by the inferior mesenteric artery. So let's talk about the stomach, which is part of the foregut. And you'll think of the stomach as a reservoir that holds food, but anatomically speaking, it's just the most dilated part of the gastrointestinal tract. So the esophagus, it pierces the diaphragm through the right crus and enters the stomach at T10 level. It has 3 layers of peritoneum attached to it, and these are the lesser omentum, the greater omentum, and the gastrosplenic ligament formed by the peritoneum. So as we saw before on that diagram, the lesser omentum is a double fold of visceral peritoneum. It extends from the liver to the lesser curvature and the first part of the duodenum. Its free edge forms the anterior boundary of the epiploic foramen, leading to the lesser sac, and it contains 3 structures: the portal vein, which is posterior, the common bile duct, which is on the right, and the hepatic artery, which is on the left. So portal vein, posterior, common bile duct on the right, and hepatic artery on the left, anterior. The greater omentum is 4 layers of closely applied visceral peritoneum. It attaches to the greater curvature of the stomach, as we've seen, and it drapes over the transverse colon, the jejunum, and the ileum. So it's just like an apron of fat over the intestines. It contains an accumulation of fat, and the gastrosplenic ligament is derived from the dorsal mesentery from the stomach to the splenic hilum. It contains the left gastroepiploic and the short gastric vessels. So what are the main functions of the stomach? Well, firstly, it's to store food as a reservoir, and also it mixes food with gastric secretions to form chyme, and it controls discharge to the small intestine via the pylorus, which is very important because the pylorus can detect food and certain chemicals and cause negative feedback loops, which can control the rate of emptying. So gastroesophageal reflux is basically when the chyme and the acid in that as well gets squeezed up into the esophagus, and it can cause damage. So there's 6 things that prevent this happening. Firstly, the lower esophageal sphincter, the LOS, the right diaphragmatic crus, the acute angle of entry of the esophagus into the stomach, the phrenoesophageal ligament, lateral pressure on the walls of the intra-abdominal segment of the esophagus, and rosette-like mucosal folds at the gastroesophageal junction. So the lower esophageal sphincter is a specialized circular muscle. It's not voluntary controlled, it's controlled automatically in the distal esophagus, and that can be subject to the negative feedback mechanisms. The right diaphragmatic crus is attached to the lower esophageal sphincter at T10, and this creates a pinchcock effect, and it exerts pressure on the lower esophagus. So if the abdominal pressure increases, then the diaphragm goes up, and then that squashes the crus, so it closes this sphincter. The acute angle of entry of the esophagus into the stomach forms a flat valve, just like any other valve in a vein, which stops the reflux happening. And the phrenoesophageal ligament contains 2 thick bands of elastin-rich connective tissue that connects the esophagus to the diaphragm. The lateral pressure on the walls of the intra-abdominal segment of the esophagus that works like the pinchcock effect. So if the stomach expands, then that will increase the pressure and close the sphincter, and then you've got these mucosal folds. So the artery of the foregut is the celiac trunk, and this has 3 branches of arteries which anastomose freely with each other. So you've got the celiac trunk in the middle here, coming from the abdominal aorta, and then you've got the 3 trunks. So the common hepatic artery, the left gastric artery here, and then the splenic artery here. So the common hepatic artery, that gives off the right gastric artery and the gastroduodenal artery. Oh no, sorry, the right gastric and the gastroduodenal, but they can be switched. And the gastroduodenal gives off the right gastroepiploic, which comes up the greater curvature. Then the left gastric artery, it supplies the lower esophagus and the lesser curvature of the stomach. And then you have the splenic artery, which comes off the celiac trunk and goes behind the stomach. And it gives the short gastrics, which supply the fundus. So this is the parts of stomach are the esophagus here, then the cardia, fundus, body, antrum, pylorus, and duodenum. So this is the fundus, and it's supplied by the short gastrics and the left gastroepiploic, which runs down the greater curvature as well. So the venous drainage of the stomach is to the portal vein, and the portal vein carries the nutrients to the liver and then back to the inferior vena cava eventually. The portosystemic anastomosis at the end of the lower end of the esophagus also takes some blood, and lymph from the whole stomach drains along the arteries to the pre-aortic celiac nodes and then to the cisterna chyli. Now these lymph nodes are scattered throughout the mesentery, and this is only in the small intestine because the stomach doesn't have any villi, but fat is absorbed via the villi into the central lacteals in the small intestine, and then via the intestinal lymph trunks to the cisterna chyli. So nerves supply to the stomach. You have sympathetic and parasympathetic supply, which runs to the intestines and the stomach along blood vessels, so it accompanies them. And the parasympathetic supply to the stomach is from the anterior and posterior vagal trunks, whereas the sympathetic supply is from the greater splanchnic nerve by the celiac plexus. The parasympathetic is generally rest and digest, so it increases the digestive activity, increases gastric motor activity and secretion, and opens the pyloric sphincter. It does this by sending branches into the wall of the stomach, which continue onto the pylorus. And then the sympathetic supply, this is your adrenaline fight and flight supply. So it constricts the blood supply, it reduces the motor activity and secretion of the stomach. So the anatomy of the small intestine, this is divided into 2 parts, and it starts at the root of so it's surrounded by mesentery as well. So the mesentery starts at a root opposite the left side of L2 at the duodenojejunal junction. Duodenojejunal junction, yeah, difficult word. Then it crosses in front of 3/4 of the parts of the duodenum, the aorta, inferior vena cava, and the right ureter, and ends in front of the right sacroiliac joint. The root is relatively short, it's 15 centimeters long, whereas the small intestine is very long, so if you stretched it out in the average human it would be about 6 meters long. This is what the different parts of the small intestine look like. So the upper 2/3 of the small intestine from the pylorus is the jejunum, and then the lower 3/5 is the ileum. So there's various differences between these 2 parts. And So firstly, the terminal ileum opens into the medial wall of the large intestine at the junction of the cecum and the ascending colon. This is called the ileocecal valve, which we'll get onto later, and it's formed by a circular muscle of terminal 2 to 3 centimeters of ileum passing through the cecal wall. So differences between the jejunum and the ileum. Jejunum is the first part and the ileum is the second part, so they're in different places. Obviously, you'll find your jejunum in your umbilical region, whereas the ileum is more in the lower suprapubic and pelvic region. The jejunum has thick red walls and a wider lumen, whereas this has a narrower lumen and it has pink walls as well, which are thin. And the jejunum has a less complex blood supply, so it has fewer vascular arteries and more long, straight arteries, like these. And the ileum has more complex vascular arteries as well as shorter arteries as well. There's less fat in the mesentery of the jejunum, but there's more fat in the ileum, and the ultrastructure is different as well. So in the jejunum you have very tall villi with long crypts, which I assume will give it a larger surface area, whereas in the ileum you have shorter villi and crypts. And the mucosa is different. So the mucosa is one of the innermost lining layers of the gut tube. So you've got mucosa and then submucosa outside of that. The jejunum mucosa is very thick and well supplied with blood, whereas the ileum mucosa, unsurprisingly, is thinner and it's less vascular. And there's fewer lymphoid follicles in the jejunum, but there's more in the ileum, which are called Peyer's patches, which we'll get into. So the function of the small intestine is to absorb nutrients, and it's adapted in several ways. So the submucosa, which you said was the outer layer of the gut tube, well, more outer than the mucosa, which is closer to the centre, and it's raised in a series of semicircular folds. Most of these adaptations are to increase the surface area, so villi in the mucous membrane, and there's more lymphoid tissue further down the GI tract as well. So in the ileal submucosa, there's aggregates of lymphoid tissue, which form Peyer's patches. So these are aggregates of lymphoid tissue, and these Peyer's patches, what they are just clusters of lymphocytes in the ileal wall. It's Peyer's patches. So the large intestine then, so we said that the small intestine joins the large intestine at the ileocecal valve, which we can see here, and the chyme goes along from there. So these are the parts of the large intestine. This is the appendix, which should be attached to the cecum, and then the ascending colon, the transverse colon, descending colon, sigmoid colon, which looks like an S, or is supposed to, and then the rectum, which means straight in Latin, although it's not usually straight in a standing human, but it can be if you're sitting down, and from the rectum to the anal canal. So we've got the ileocecal valve, where we said is the junction between the terminal ileum and the cecum, and that's made of circular smooth muscle. So yeah, this is cecum, ileocecal valve, terminal ileum. This is the opening to the appendix, and that's the appendix here. So the large intestine is 1.5 meters long. It's considerably shorter than the small intestine, about 4 times shorter since it was 6 meters. And there's 3 features that you can use to distinguish the large intestine from the small intestine, apart from the fact that it's going to have a larger diameter. So these are more detailed things like the Taeniae coli here. So these are condensations of the longitudinal muscle into 3 bands. You've got haustra or saculations, which are these bumps here. These bumps which appear because the longitudinal muscle is shorter than the rest of the wall. So I reckon it's sort of like a scrunchie, basically. The longitudinal muscle on the inside is shorter than the other muscle on the outside, so it just scrunches up. And the appendices epiploicae, which are small tags of fat that kind of look like lymph nodes projected from the wall. So the large intestine's main function is, unlike the small intestine's function of absorbing the nutrients, this absorbs the water and the electrolytes. So about 1 litre of water enters the large intestine per day from the small intestine, but less than 100 millilitres excreted, so about 90% of the water is absorbed. So the peristalsis in the gut tube is all to do with the slow waves and action potentials, but basically on an anatomical level, in the colon, they're not as frequent and they're not continual but more periodic, unlike in the small intestine where they are continual. The lymph drainage of the large intestine is first to the nodes in the mesentery and then the pre-aortic nodes on the posterior abdominal wall and then the cisterna chyli. So it's much like the small intestine in lymph drainage. Vascular supply of the GI tract. So as we mentioned, the abdominal aorta gives off these 3 branches, the celiac trunk, the SMA and the IMA, so the mesenteric arteries, and they supply the majority of the GI tract. The upper rectum and the anal canal is supplied by the superior rectal arteries, and these drain to the portal vein via the superior rectal veins. So let's talk about the superior mesenteric artery, which is the artery of the midgut, and this supplies the second half of the duodenum, all of the small intestine, and the large intestine up to the 2/3 of the transverse colon. So most of the small intestine, well, all of it, and a part of the large intestine. So this picture, the mesentry's been expanded, and you can see more clearly where the arteries run. So the superior mesenteric artery has 6 branches. You've got the inferior pancreatico-duodenal artery, the middle colic artery, jejunal ileal, right colic, and ileocolic arteries. So the inferior pancreatico-duodenal artery, that supplies the duodenum beyond the middle of the second part. Got the middle colic artery, which supplies the transverse colon, as you can see here, and the jejunal and ileal arteries supplying the jejunum and ileum. The right colic artery, which supplies the ascending colon here on the right, and you have the ileocolic arteries here, which divide into the anterior and the posterior cecal arteries. The posterior cecal arteries then give the appendicular artery, which goes to the appendix. So the marginal artery is an anastomosis between the ileocolic right, middle, and left colic arteries, which forms a continuous arterial line at the margin of the large intestine from the cecum to the rectum. And within the mesentery, the branches are joined by these vascular arcades. There's fewer arcades in the jejunum, as we said, with longer straight vessels, and more complex arcades in the ileum. The inferior mesenteric artery is the artery of the hindgut. So we've got the left colic artery, which supplies part of the transverse colon and the descending colon. The sigmoid branches, which supplies a sigmoid colon. The superior rectal artery supplies a rectum and anastomoses with the middle and inferior rectal arteries from the internal iliac artery. This is a branch of the internal iliac artery, and middle and inferior rectal arteries, which are branches of the internal iliac artery. Then you've got the venous drainage to the internal iliac veins and then to the systemic veins. So that was pretty much it. Let's talk about some clinical applications and what can happen when things go wrong with the GI tract and this part of the abdomen. So firstly, we have peritonitis, which is a bacterial contamination of the gut during surgery or gut rupturing and can result in infection and inflammation. So things will get out and infect the peritoneal cavity. Things like gas, gastric contents, bile, fecal matter, this can all will leak into the peritoneal cavity, and it causes referred pain in the overlying dermatome. And also, because if it's in the front, it can affect the muscles, so it can cause rigidity in the anterior abdominal wall muscles. You can see the inflammation here. And then we have ascites or ascites, not really sure how to say that. This is just excess fluid in the peritoneal cavity, so you can see that here does not look very pleasant. So you can see a normal abdomen and then the fluid in the ascites here. And this can result from cancer, secondary carcinoma, or cirrhosis. GORD, as we mentioned before, is gastroesophageal reflux disease. This is when the acid goes back into the esophagus from the stomach, and is sometimes known as heartburn or acid regurgitation. It can be caused by incompetent cardiac sphincter and a hiatus hernia here, which you can see. So that's when a portion of the stomach prolapses through the esophageal opening in the diaphragm. It prolapses upwards and then causes the heartburn. Peptic ulceration. So that's posterior gastric ulcers, which can erode the splenic artery as well. This can cause massive bleeding, and gastric contents may enter the lesser sac, which is not good. So you can see here, maybe some of the mucus is very thin or something, and then that can cause an ulcer. So pyloric stenosis is a narrowing of the pylorus here, and it can be congenital or acquired. So congenital cases are often in boys in early weeks of life, and this can cause, because this bit is blocked, so this can cause projectile vomiting without the presence of bile. And you can also get this by scarring from peptic ulceration, so the scarring increases the thickness of the muscle here and blocks the pylorus. So you have stomach cancer. Stomach cancer, which usually has a poor prognosis because it's very difficult to remove the cancer. This sort of looks like an ulcer, but it's not. It's very difficult to remove it because the lymphatics are very extensive, so it's difficult to remove from the very complicated network that's in here. Appendicitis is quite common. It's the inflamed appendix, which causes thrombosis of the appendicular artery, which, as we saw, supplies the appendix, and this causes subsequent necrosis and perforation. Now, referred pain in the early stages, so the pain sort of migrates its way throughout the course of the infection, and in the early stages it's referred to the T10 dermatome, so you feel it in the skin around your umbilicus, and then it irritates the overlying parietal peritoneum, which is supplied by somatic nerves, which means that you can feel it. So the pain is felt in the right iliac fossa, and then that's how the pain moves, basically. So locating the appendix is described as vermiform, which means it's like a little worm, so it's mobile, is on a mesentery, and it can be in different positions, which can make it very difficult to locate. Now, the surface marking used to locate the appendix is called McBurney's point, and as you can see here, it's 1/3 along the way from basis to the umbilicus. So 1/3 from the anterior superior iliac spine to the umbilicus here. Then Meckel's diverticulum is an embryological remnant of the vitello-intestinal duct. That's here, and it can be inflamed. So this in the embryo connects the gut tube to a yolk sac on the antemesenteric border of the bowel, and it is disappeared after birth, but it can remain in some people, 2% of people. It's typically 3 to 5 centimeters long, and it's found within 60 to 100 centimeters from the ileocecal valve, so 60 to 100 centimeters. Now, situs inversus is a very rare disease. Well, it's not a disease actually. It's just a congenital thing that people are born with, and it's basically where all your organs in your abdomen and your thorax are flipped to the opposite side. So, for example, here, this person has their lungs switched around, and it looks like their heart is mirrored as well as all their abdominal organs. And this can make things like appendicitis surgeries quite difficult, because the surgeon has then got to work out different anatomy. So the appendix can be in the left iliac fossa now. And then you can have a condition called congenital malrotation of the gut, which is where the normal bowel rotation doesn't occur fully, so the appendix is in an abnormal position from birth. So, yeah, that's basically all about the anatomy of the abdominal cavity. If you enjoyed this video, please leave a like and subscribe and comment, and have a good one.